Well, in essence of time, good afternoon and welcome back for our third session in Uncontrolled Hypertension and COVID-19 Learning and Action Network. As mentioned in prior sessions, my name is Caitlin Conway and I am a chronic disease and patient family engagement lead here at Mountain Pacific Quality Health, and I am accompanied by my colleague Stevie Tsai, pharmacist and senior manager also at Mountain Pacific. Throughout today's session, please feel free to utilize the Q&A feature at the bottom of the screen or the chat function. We will also have time at the end for live discussion. Before we dive into today's content, I would briefly like to highlight the COVID-19 numbers in our state. So as you can see, we are seeing dramatic increases across our region throughout all of them. Our team will continue to monitor and support our communities throughout these times and help share and spread best practices and lessons learned. As we keep those numbers in mind, I would now like to introduce you to our guest presenter today. We are very honored to have Dr. Eduardo Sanchez with us. Dr. Eduardo serves as the Chief Medical Officer for Prevention and Chief of the Center for Health Metrics and Evaluation for the American Heart Association, and he oversees the work of the AHA Center for Workplace Health. Prior to joining AHA, he served as Vice President and CMO for Blue Cross and Blue Shield of Texas, and before that, he served as the Director of the Institute of Health Policy at the University of Texas School of Public Health. Dr. Sanchez served as the Commissioner of the Texas Department of State Health Services from 2004 to 2006, and Commissioner of the Texas Department of Health from 2001 to 2004. He oversaw the SARS response in 2003 and 2004, the flu vaccine shortage of 2004, and the response to Hurricane Katrina and Rita in 2005. He served as the local response and public health officer in Austin, Travis County from 1994 to 1998. He currently serves as the Board of Directors of Trust for America's Health. He has served on numerous health-related boards and advisory committees at the local, state, and national levels. From 2008 to 2012, he served as the chair of the advisory committee to the Director of Centers for Disease Control and Prevention. Dr. Sanchez obtained his MD from the University of Texas Southwestern Medical School in Dallas, an MPH from the UT Health Science Center at Houston School of Public Health, and an MS in Biomedical Engineering from Duke University. He holds a BS in Biomedical Engineering and a BA in Chemistry from Boston University. Dr. Sanchez is board certified with family medicine. So I would like to hopefully introduce you to Dr. Sanchez. The floor is all yours.
All right, can you all hear me?
Yes, we can.
Okay, and do you want to see me or do you just want to hear me?
I think you're okay with just going with just the hearing for now. I think they can see the slides.
Okay, perfect. So I so appreciate being on, and I so appreciate the invitation. It's been interesting times. Here we are doing Zoom calls, and what used to be the stress associated with trying to get through security in an airport now is the stress associated with getting on a Zoom call and not having things get messed up. And I think we managed to get things on for today, so I'm very appreciative. So if we go to the next slide, what I'm going to talk about is high blood pressure control from what to now. And would like to say that from the very beginning, as it related to COVID-19, it was clear that we wanted to be paying attention, because from the perspective of the American Heart Association, the fact that case fatality rates were higher in persons who were age 80 or older, age 70 to 79, persons with cardiovascular disease, diabetes, and hypertension, compared to a case fatality rate that was about 2.3% in that first group that was looked at in China, we were going to be paying attention. The fact is that as the pandemic, what became a pandemic moved into Europe, we saw similar higher case fatality rates among persons 65 and older, persons with cardiovascular disease, persons with diabetes and hypertension. Next slide. That observation has changed in the United States, because compared to many of the countries where the pandemic first hit and hit hard, the United States has a higher obesity rate. And it has become clear, at least to the CDC and others that have been looking at who's affected by COVID-19 in the United States, that obesity plays a role. And when I say the United States, I mean extending into territories, et cetera. It's become abundantly clear that obesity is playing a role. Serious heart conditions as defined by heart failure, coronary artery disease, and cardiomyopathies also increase risk according to CDC, as does type 2 diabetes. And you know, anyone on this call recognizes that those three categories in red coalesce. They're interconnected, and there are people with comorbidities. Next slide. The second category that CDC has characterized is the category of people who might be at increased risk of severe COVID-19. I think from the perspective of messaging to our patients, I am somebody who says, whether in public or to individuals, that if you are somebody with an underlying medical condition, pretty much of any kind, you should act as if you have the most highest risk underlying condition. You just don't want to get COVID-19. And in fact, I've gone so far as to say, even if you are the healthiest, risk-free person walking around, you don't want to get COVID-19. A, you don't know how it's going to affect you, and B, you don't know if you will infect somebody else in whom it will have a dramatic consequence. But here's a list of folks that might be at increased risk. Cardiovascular disease, I would say that's the category that isn't in the others. Atherosclerotic disease might be one. Hypertension, smoking, and type 1 diabetes. Next slide. One of the things that also has become clear in the United States as we have looked at race ethnicity data is that COVID-19 has been disproportionately affecting some groups more than other groups. And this is but one characterization out of APM Research Lab. There's other data, but it aligns with this, and that is that compared to whites, the age-adjusted COVID-19 mortality rate for black persons is 3.8 times as high, almost 4 times higher. For indigenous people of the United States, 3 times higher. For Pacific Islanders and Latinos, pardon me, about 2.5 times higher. And for Asians, 1 times as high as that for persons who are white. Next slide. Now, as you know, back up a second, back up to the previous slide just for a moment. So this disproportionality has, when one unpacks why around the disproportionality, let me just say what is probably known here. And that is that when we look at things like cardiovascular disease, hypertension, type 2 diabetes, and obesity, there is a difference in the prevalence of those conditions. And in general, not in all cases, in general, African-American people, indigenous people, Pacific Islanders, and Latinos in particular fare worse in most of the categories of cardiovascular disease from a prevalence perspective. Cardiovascular disease, hypertension, type 2 diabetes, and obesity. So on the one hand, there's a higher burden of underlying medical conditions that could lead to severe COVID-19, including mortality. There's another set of factors on the front end. There are some socioeconomic factors that appear to be associated with a higher likelihood of being infected. And those of you who remember from your infectious disease and communicable disease classes or even CME Now, the more you are exposed, the higher the likelihood that you will be infected. And so if you are a person who stays home during COVID-19 and never ventures out of your home, and you live alone, and everything comes to you and is left at the door, the likelihood of infection is low. But if you are somebody who is out and about because you have to be, or because you want to be, but if you have to be, you don't have a choice. It could be the kind of work you do, whether that's working in a meatpacking plant, working in a hospital, being a first responder, being somebody who drives a bus in an urban setting. You are exposed more than other people. And so just by sheer exposure, the likelihood of infection goes up. And then there's the issue of the circumstances in which you live. If you are a person who is in a household with lower income than the average, or lower income than higher income people, and I notice I misspelled disproportionality, and I apologize, then it is likely, or it is possible, that you are living in a setting where lots of people live in a small space. And that just also is a recipe for the likelihood of infection. So let's move on to the next slide, because I want to share some insights about high blood pressure. A very recent study published in JAMA by Paul Muntner and others. Paul Muntner was on the 2017 AHA, ACC, and many other organizations high blood pressure control guideline. They've looked at some data to see how is blood pressure doing now in the last 15 years or so, 20 years, and how has things changed because of the hypertension guideline. And the headline associated with that study was that blood pressure control has gone down in the last 4 years. And it's not entirely clear why, but I wanted to look at the data from a different angle. And I just want to share this with you because I think there's some insights here. And this is the percent of blood pressure control. And by age, you can see that blood pressure control is highest among 64 to 74 years old, and lowest among persons over 75, and about the same, I would say, in 45 to 64-year-olds. Next slide. By sex, females seem to have a higher level of control than males. By race, ethnicity, next slide, and these slides have highlighted the section I'm going to talk about. You can see, and I'm going to point this out to you, for non-Hispanic white persons in the United States, the level of control approaches 50%, whereas the level of control for non-Hispanic Black persons, non-Hispanic Asian persons, and Hispanic persons is more around 41%. That's a big difference. Next slide. In this slide, this has some socioeconomic factors. Education matters, and you can see that less than a high school education, lower level of control than high school and some college, and then it gets even higher if you're a college graduate at 48%. Next slide. When you look at income, again, there's a demarcation. One of the demarcations is that if you have less than $20,000 a year annual income, blood pressure control is much lower than if you are higher than $20,000 a year. But you'll also notice that the $20,000 to $45,000 is lower than $45,000 and above, which approaches 50% and exceeds 50% for $75,000 a year or above. Next slide. This one looks at type of insurance, and for people with private insurance, it's about a 48% control level. People on Medicare, 53%. People on Medicaid, it comes down to 41%. And for the uninsured, it's 24%. And then the last of these categories, people who identify as having next slide, a usual healthcare facility. for care versus no usual healthcare facility, you can see there is a dramatic difference. And so for me, one of the take homes is, as we think about how do we improve blood pressure control, perhaps we need to figure out how we focus on those individuals who do not have usual access to health care and try to get it, identify those who don't have insurance and try to get them insurance, try to figure out over the long haul how we can graduate more people out of high school, and that's the very long haul, graduate more people out of high school, which would have the likely effect of having them be in a higher income bracket, which provides health insurance and or provides the resources necessary to be able to afford the co-pays and for doctor's visits and co-pays. Next slide. So these are some health statistics for Native Hawaiian Pacific Islanders, and you can see that as far as obesity goes, the prevalence is substantially higher among non-Hispanic Pacific Islander persons compared to non-Hispanic whites. Hypertension is about the same. Coronary heart disease is a little bit higher, and diabetes is substantially higher. So when you combine obesity and diabetes, you get to a place where, at least as it relates to COVID-19, there may be some issues. I would say that this is the reminder that people don't walk around with this one condition. And so even as we might be focusing on getting blood pressure under control, it's critically important that these other comorbidities, underlying health conditions, people who have obesity with their hypertension, or people who have diabetes with their hypertension, or people who have all three, is critically important. Next slide. So I'm going to close by talking about Target BP. Target BP, BP for blood pressure, is a program that the American Heart Association and the American Medical Association have put together, which I would say are meant to do a couple of things, three different things. One is to provide practices with the resources that they might need to improve blood pressure control in their practice. The second is a practice transformation opportunity to do a few things better in the delivery of clinical care that should result in better blood pressure control. And the last is a recognition program for those that are doing it well. And I'm going to focus on what's on the left side of this slide. The MAP BP Improvement Program has three essential elements. M in MAP is for measuring accurately, A in MAP is for acting rapidly, and P in MAP is for partnering with patients. The measure accurately is that it's become very clear, the science is clear, it's written in the guideline that measuring blood pressure well is very, very important. And the AMA and the AHA have focused attention on doing that right, have focused attention on making sure that there is some training available to train staff on how to do blood pressure measurement better. And while you and I may think, well, that's an easy thing, everyone knows how to measure blood pressure. When you actually test, we find that there is opportunity to do better. And when you train, that gap in competency goes up, and people are able to, the gap goes down, the gap is closed, the competency improves, and people who are measuring blood pressure do a better job. The other is not only train how to do it well, but also training patients on how to be prepared for blood pressure. And some of you have seen, and if you haven't, we will make available to you the red infographic, as we lovingly call it, that has the 7 things that should be happening when you get your blood pressure taken, or the 7 things that should or shouldn't be happening. So when you get your blood pressure taken, you shouldn't have any part of your body crossed over another part of your body. You should have both feet on the ground. Your blood pressure should be taken at heart level. You should have an empty bladder. You should have a 5-minute rest at least before your blood pressure is taken. And so those things are captured in an infographic that's meant to, A, be in the location where blood pressure is taken as a reminder to both the person taking the blood pressure and the person whose blood pressure is being taken. But we also can hand those out so that people know what they should and shouldn't be doing. The other thing we know about measuring accurately is that we should be using devices that have been tested and validated. And the AMA, with the AHA in the background and providing support, has now stood up a validated device listing website, VDL. And while the list is short in the moment, because this VDL listing is only several months old, the list is growing. And the point is that you should be using in your practices, and you should be advising your patients that might have home blood pressure monitors that they should be purchasing blood pressure monitors that are on the VDL list. Speaking of which, I'm going to take an aside on Measure Accurately. Earlier this year, a scientific statement was released, a joint scientific statement between the AMA and the AHA on self-measured blood pressure monitoring. That's critically important because we're finding that when people measure their blood pressure at home, we get better control, and it helps clinicians manage blood pressure with some decrease in the inertia and challenge. So let me go to Act Rapidly. Act Rapidly is the idea that we need to overcome clinical inertia. I am guilty in the days that I did clinical care of having the patient come in with a blood pressure of 142/92 and thinking to myself and saying to that patient, oh, it's just a little bit high. Let's try these things for a few weeks that would turn into a few months. And lo and behold, the patient who I was seeing would be walking around with slightly elevated blood pressure. And what we know is that slightly elevated blood pressure is causing some end organ damage. It doesn't cause it as severely, it doesn't cause it as quickly, but it causes it slowly, and it is additive to what might happen as blood pressure control gets out of control. So acting rapidly is providing clinicians the information they need in the moment, that it is time to take care of business, to make sure that the patient has the opportunity to know that this is a time when maybe we need to add another medication to your treatment regimen. And so the MAP program provides the means by which that therapeutic inertia index can be captured and not only act in real time, but also act where the team comes together and maybe once a month looks at how they're doing, and that team can find, oh, 20% of the time there was an opportunity to intensify care and we didn't take it, and that has resulted, and that results in more likelihood that care will be intensified appropriately when those opportunities arise. And then the P is about partnering with patients, and that includes the home blood pressure monitoring, but also includes the healthier eating, a DASH diet, the engaging in physical activity, hopefully 150 minutes of moderate to vigorous physical activity, the moderate, if any, use of alcohol, but the self-measured blood pressure, again, a scientific statement came out that says this helps, and there is a infographic that helps patients with how to do home blood pressure measurement on their own. And let me come back. I'm going to talk for a minute I'm going to come back to Measure Accurately, because one of the things that the AHA has done in partnership with the AMA is created a little training module, an e-module that helps that medical assistant or whomever is doing blood pressure measurement in the practice to learn how to do it right and do it well. So I think I'm going to move on to the next slide. If there is one, and teamwork, absolutely. And I do want to appreciate that I'm talking, and behind me there is the marionette. I'm just the puppet who are feeding y'all information that can be used. So here's the here's the blood pressure program all over again. I've kind of gone over, I think, all of the elements that I wanted to cover today. Next slide. And the next slide is one I was involved in writing this paper a few years ago, and it's the reminder, and in the MAP program they talk about this, is that it is helpful to use a hypertension, high blood pressure control algorithm or protocol in your practice. And best practice is to bring the team together, all the members of the team that are doing clinical care, nursing staff, physician staff, the MA, if you're not including that as a nursing staff, anyone else who's involved in kind of touching the patient, and trying to develop an algorithm that works for your practice, given what you look at, your practice, given what might be on the formulary. And I believe, and it's written into the paper, these algorithms ought to be understandable by patients, kind of like the red infographic, so that a patient would know if this is what happens at this point, this is what I should expect my doctor to be doing. And it serves as a reminder that one of the members of the team and the healthcare team is the patient. Next slide. So just to conclude, the practice change elements are critically important. I talked about most of these. I'm going to talk about the last two on practice change in a moment. Target BP is the MAP program. But remember, I talked about overcoming inertia. In order to know whether you're overcoming inertia or not, and the degree to which you're doing it, you have to have a registry. You have to know who in the practice has high blood pressure, how are we doing with blood pressure control, and then, as I mentioned, how are we doing on clinical inertia? So the elements for practice change are target BP, a guidelines-based algorithm, team-based care, which I talked about, a registry, and monitoring how you're doing. And then I believe it's critically important when possible to think about the community linkages. Not only are people taking their blood pressure at home, but they might be getting their blood pressure taken outside of the home. And community health workers can serve as extensions of the clinical care practice and maybe help patients at their home understand how to take their blood pressure, maybe help them understand how to do some of those lifestyle changes. There's good evidence that engaging pharmacists can improve care, engaging barbershops and salons as community health workers can improve care, and faith-based settings and faith-based health ministries can help improve care. So I'll stop there. I realize we have probably very little time. I'll do my best.
Thank you, Dr. Sanchez, for that excellent dive into hypertension and the way that COVID-19 can impact that, and also the very important social determinants of health that we all need to have our eye on when we are working with these patients. If you do have any questions, please feel free to pop those in the question and answer field or via chat. You can also reach out to us via email. Jessica Newmeyer has put her information in there for the American Heart Association, or you can reach out to Caitlin Conway or myself at Mountain Pacific Quality Health. As we wrap up today.
So can I answer a quick question about which is more accurate, manual or electronic machines? The evidence is beginning to make clear that electronic machines work better. But if you're in a practice where you can't afford or you don't have enough electronic machines, manual blood pressure checks are a good screen. If a person's blood pressure is normal or controlled, you could feel confident that that's right. If it's elevated, you should get the electronic machine confirm that what you measured with a manual blood pressure machine is verified, corroborated by the electronic machine. That's a way to do it.
Janice, recordings of these events can be found online at mpqhf.org. We also email them out to attendees once they are uploaded. As we leave each other today, we do have some leaving and action suggestions for you. First, we've talked to you twice now about the importance of proper blood pressure measurement. This is because it is truly critical to improving those outcomes. We'd like you to find your policy or procedure and then make sure that it's being followed. If you don't have one, find one that you like and put it in place. Find your hypertension treatment algorithm for your care setting. If you don't have one, again, find one that you like and put it in place. We are happy to assist with those things. Verify that your algorithm is being followed and that it's working. Look for those workarounds that are indicating that it's not a great fit for your care setting. And then last, look for those things that you can identify that you're currently doing that are engaging patients and educating them. And then find the gaps. Look for those self-management programs that would work for your patient population in your setting, particularly for the self-monitored blood pressure programs. Please remember that Mountain Pacific is here to help support you if you would like to be a part of a team-based care affinity group or a self-monitored blood pressure program affinity group. Please reach out to us. Thank you everyone for your time. Thank you Jessica and Dr. Sanchez for joining us today. As always, if you have any questions or concerns, please reach out to myself, Stevie Tsai, or Caitlin Conway at Mountain Pacific Quality Health. Thank you.
Thanks all. Have a wonderful day.
Thank you. Sorry to scare y'all.
It was great. Thank you.
It was a touch and go. I was a little panicky. I'm glad it all worked out. And again, I swear, it's the COVID equivalent of almost missing an airplane.
Yeah,
you were right on time.
Yeah, you were perfectly on time. Wonderful. Thanks, everybody. Thanks again. We thank you for your great presentation. Take care.
So long.
Bye.